Hello, everybody. Good afternoon. I'm Elena Garcia Peraza. I'm a Global Medical Manager for Vetoquinol. And thank you for joining this international webinar regarding the application of remote diagnosis and management for osteoarthritis in dogs. Since COVID-19 stepped into our normal way of life, all of us had to adapt to this situation. And we had to transform our way of work, the schools for our kids, and our social behavior. But we didn't have in mind that keeping social distance would be a need in our daily life for such a long time. So the main objective of Vetoquinol is therefore to provide solutions like the expertise program for veterinarians to build profitable businesses based on excellence in vet care for those engaged in it. We will also provide you a link for the recorded session organized by our team in the USA during confinement, and it was dedicated to telemedicine, which may give you some ideas for developing a virtual care program in your practices. Vetoquinol as well is organizing a digital congress dedicated to osteoarthritis in dogs next November 19 and 20. And for 2021, several international webinars for different domains. So with all these actions, we would like to support the veterinary community. And now Alexander will give you some tips about the questions and answers. And then after we will introduce Dr. Lascelles.
Thank you, Elena. So welcome everyone. Just a quick reminder. During the presentation, you will be able to ask questions to Dr. Lascelles. You will answer them at the end. Also, you will have a quick survey that you need to fill at the right, that will pop on the poll section. And it's important, we invite you to fill the poll to have your feedbacks and allow us to improve our webinar sessions. Thank you.
Today, we're very pleased to have Dr. Lascelles as speaker. As you may already know, he's an expert in pain management, director of the Comparative Pain Research and Education Center in North Carolina, and his main interest in research is the translational research in pain dedicated to answering critical questions about pain control and pain mechanisms. All of it through high quality and innovative research with more than 200 scientific publications. So welcome, Dr. Lascelles, and now is your turn.
Thank you very much, Elena, for that lovely introduction. And hello to everyone. Thank you for joining me. Today, I want to talk about the remote diagnosis and management of osteoarthritis in dogs. And I think historically we've focused on the hands-on component when we think about diagnosing and evaluating OA in dogs. But today I want to show and discuss with you that osteoarthritis evaluation and diagnosis is so much more than just the hands-on component. And indeed, those aspects do lend themselves to being done remotely. Now, all of this discussion has been brought on by this COVID-19 era that we are in. And I'd like to kick off by saying, firstly, I hope you're all well, both physically and mentally. These are tough times, and I hope you're all doing well. So on to then the discussion on the remote diagnosis and management of osteoarthritis in dogs. Now, I've titled this Musings. This is really a discussion. Hopefully you will find some interesting pieces that you'll be able to take away and incorporate into your practice to improve the way you approach the management of osteoarthritis. Before we get going, I am very honored to be part of this Vetoquinol Academy set of presentations, and I encourage you to visit the Academy website. There are some other great webinars talking about how to practice in this COVID-19 era and maintain optimal patient care. And I've just highlighted one of those presentations there. We're going to be talking about osteoarthritis in dogs. So I think we do need to talk a little bit about the prevalence of osteoarthritis. Now, the prevalence of the disease of osteoarthritis is relatively unknown. What we do have much data on is the prevalence of osteoarthritis-pain, that is the presence of disease and pain associated with that. And when you ask someone, this number of 20% trips off their tongue very easily. 20% of all dogs have osteoarthritis pain. However, recent evidence suggests this is nearer 40%. So 2 out of every 5 dogs have osteoarthritis pain. And of those, interestingly, only about half of them are actually treated. So just to summarize, when it comes to thinking about how common this disease is, we don't really have a good handle on that, how common the actual disease is. But in terms of pain associated with osteoarthritis, that combination, it's roughly about 35 to 40% of the canine population suffer from osteoarthritis-associated pain. Now, I think this is where we currently are in terms of our approach to the diagnosis of osteoarthritis. We feel comfortable with the idea of the hands-on evaluation. We may not be totally comfortable with performing the hands-on evaluation, but that's what we think about when anyone brings up the subject of diagnosing osteoarthritis in dogs. However, things have changed recently. COVID-19 has influenced our approach to practice, our approach and what we can and can't do. And we've been moving to more remote consultations, this idea of telemedicine. And I think what everyone, certainly my experience is, what we've been trying to do is to decrease visits, to decrease individual person traffic into our practices while still maintaining patient care. Interestingly, though, I think what I'm presenting today, at least it's taught me that what's been forced on us is not just maintaining patient care, but I would argue optimizing patient care. And I think this will hopefully become clear as I talk through this. I'm going to talk about some aspects that I think actually optimize patient care as opposed to just maintaining patient care. And once we get back to a normal routine, I think if we can keep these aspects incorporated, we absolutely will optimize and improve patient care. So before we get into this, I want to give a sort of high-level overview of the orthopedic examination for diagnosing and monitoring OA. The goals are really to identify the location of OA pain, and then secondarily to identify the impact of that OA pain on the whole patient. And as I've already mentioned, historically, we think about doing this through the hands-on orthopedic evaluation. But prior to that, there's arguably an even more important component, and I've certainly been taught the value of this by mentors such as John Holton at Cambridge, Simon Rowe and Duncan Lascelles at North Carolina State University. You learn a lot. You gain a huge amount by observation, careful, thoughtful observation of the whole patient. And that is an integral and important part of the orthopedic evaluation. And then another very important part is the owner observation, which is essentially the history, what the owners are seeing, and capturing that information and incorporating that into this overall orthopedic evaluation is very important. And even prior to that, another important step is it's essentially owner education. Do the owners recognize that there may be a problem? And that's certainly something that I think often we need to overcome. We may see the problem, the owners may not. And so there's a degree of owner education needed there. So let me start off by talking about monitoring current OA cases. So let's put diagnosis to one side for the moment. And let's just talk about monitoring those OA cases that you know of that are part of your practice at the moment. And I'm going to kick off by talking about CMIs. These are clinical metrology instruments. And this is the tool, these are the tools that we use to monitor the impact of OA pain on our patient. So we're measuring OA-associated pain using these clinical metrology instruments, and these are owner questionnaires. So clinical metrology instruments is just a posh term for owner questionnaires, and these are owner assessments. Owner assessments are important because it's the owner who is seeing that patient day in, day out in the home environment and can tell us so much about the function and well-being of that individual. There are two main CMIs or owner questionnaires that I would recommend to you. There are others. These are probably the most validated questionnaires. The Liverpool Osteoarthritis in Dogs Index, so-called LOAD, and the Canine Brief Pain Inventory, the CBPI. Just a few words on what metrology is and what a metrology instrument is. So metrology is measurement-based informatics. It's measurement science and measurement technology. And a clinical metrology instrument is a sequence or series of questions relating to a clinical disease or process. The response is based on subject, if you're a human assessing yourself, or proxy, if you're a human assessing your pet, assessment. And these responses, so it's a series of questions, they're answered, and these responses generate an instrument score. And in the context of a clinical metrology instrument to score the impact of OA pain on the patient, that score directly relates to that owner's assessment of the impact of OA on their pet. And using these CMIs, these owner questionnaires, allows us to stage a disease or process. And they have some very useful attributes. They provide consistent information. Because it's a set series of questions, we're always getting the same information back. That allows us to follow changes over time and interpret the results of interventions. I don't know about you, but when I'm taking a history freehand, if you like, the questions I ask are the first ones that come into my head. I'm not always asking the same questions, not always in the same way. And there's a lot of value in consistency, in asking the same questions. Also, the questions have to be valid. And I mentioned the two questionnaires, the LOAD and the CBPI, are probably the most validated. They are validated as measures of the impact of OA pain on patients. So these are the URLs for the Liverpool Osteoarthritis in Dogs Index and the Canine Brief Pain Inventory. And you can go to these URLs and you can download these as PDFs. The LOAD is actually a fillable PDF, which, as we'll talk about later, you can send to clients. And here is the LOAD, and this is the part of the LOAD which assesses the impact of OA pain on that pet. So as you can see here, a series of questions. How is your dog's mobility in general? The owner selects an answer here, and in the fillable PDF, then a number is created in this column here. So the owner completes these 13 questions and a score is created, which is a measurement of the impact of OA pain on that patient. Now, obviously well, maybe not obviously, but they do come in paper versions. That's, if you like, the standard way of using them. But what we want to do is do this remotely. And so these CMIs can be completed over the telephone. Even better, they can be sent to the owner. As I mentioned, there are electronic fillable PDF versions available. They can be sent to the owner by email, text, WhatsApp, however you prefer to communicate with owners. And you ask them to complete this questionnaire as a part of the assessment of OA pain in their dog. And emphasize there are no right or wrong answers. We'll hopefully remember I'll come back to talk about the placebo effect and how that may alter answers. But emphasize there are no right or wrong answers. This is you're capturing the owner's assessment, and to a very large extent, the owner is correct in that assessment. And just a few words about what these CMIs actually capture. So these clinical metrology instruments capture information about multiple dimensions that relate to well-being and health and are impacted by chronic pain. So chronic pain doesn't just impact gait and movement, it impacts function, the ability to perform the activities of daily living, impacts sleep quality, somatosensory processing, cognitive function, social relationships. And these CMIs, these owner questionnaires, capture information across these multiple dimensions. They capture information on the influence of pain on these multiple dimensions. So that's capturing the owner assessment. Now, the next part of the ongoing evaluation of osteoarthritis cases is your observation. So how do you do that? Maybe if you're not seeing the patients as you were prior to COVID-19 era, well, I would argue this can be done through owner-captured video. And this is essentially your observation that is being made through video that the owner is capturing. In order for this to work, you need to provide some sort of clear, or you need to provide instructions, and ideally clear instructions on how to do this. What I found is that without clear instructions, you do not get good quality video from owners. You do not get video that you can use to evaluate these patients. So provide clear instructions, and I think some important points to incorporate in those instructions are that the surface should be even, level, ideally a hard surface with no distractions in the area. The lighting should be good. So you want that kind of medium flat lighting. So the ideal situation would be a day that is bright but with cloud cover. What you don't want is the dog to be moving from bright sunlight into the shade. You don't want generally poor lighting. So that's probably the most difficult thing to get right and communicate to owners. And then ideally, what we want owners to capture video of the dog doing different gaits. So trot, walk, and performing activities such as going up and down stairs. These all tell you different information and are very useful. In order to communicate what you want to owners, there is a useful video here, this URL, it's a YouTube video that explains canine gait to clients, explains the difference between trot and walk to help them collect the appropriate gait. Try and encourage the owner to take different viewpoints. You see the camera here, it's good to get a low down viewpoint or kind of at animal level, at dog level. Rather than everything coming from above, as you probably would get if the person was standing up and pointing the camera at the dog. Importantly, agree or recommend on file formats. You don't want to be frustrated with trying to convert files in order to be able to view them. So think about what formats you can view and recommend those file formats, and also give recommendations and clear instructions on how to transfer those files. You could use shared Google Drives. There's a way of setting up privacy so owners can upload videos but not see other people's videos. You might have an FTP site in the practice. What I found doesn't work so well is having them emailed and sent by text, because then they're coming in from all sorts of different sources, and the onus is then on you to go to those sources and refile those videos. When you get these, this is an assessment, so take it seriously. Save and log these videos with identifiers, the patient, the date. Have a decent screen to view these on. This is not something where you want to be, viewing the videos on your phone on that little screen. So sit down, take the time, have a decent screen, slow the video down if needed. Which is particularly important for small dogs and cats. I ask owners to collect the video at normal speed in order to minimize file size, and then I'll slow them down to evaluate them. And then enter your assessment in the patient's record. Now you're thinking that all of this is going to take time, and you do need to think about how to monitorize, charge for that time. But what we're doing here is, instead of doing the evaluation in the clinic, we are doing a valuable, important, and serious evaluation remotely. So this does need to be communicated to owners that this is in lieu of that visit to the clinic. Okay, so that's monitoring ongoing cases. You'll get a lot of information from the owner assessment and from those videos, and encourage you to make those part of the patient record. How about diagnosing new cases of osteoarthritis pain? Well, I think there are a number of stages to this, and there's certainly going to be a lot of overlap with what we've just talked about. But in order to be able to diagnose a new case, there needs to be some sort of index of suspicion. And that's where these so-called checklists come in. So we'll kick off by talking about those first. Checklists are screening tools to open up a discussion about the possibility of osteoarthritis being present. They are not for diagnosing osteoarthritis, they're for opening up the discussion. Here's one example. This is one that Vetoquinol has produced. They are generally very visually friendly. They are designed for owners. The idea here is that you put this information in front of owners and you ask them to answer these questions. And essentially, most of these checklists go along the lines of, if you can answer yes to any of these questions, then your dog may have osteoarthritis. Again, this is not a way of definitively diagnosing osteoarthritis, but it allows that conversation to be opened up. And so here you can see, you know, if there's been any personality change, if there's been reduced mobility, changes in gait or limping. So if the owner is answering yes to these, again, just emphasize, it allows you to open up that conversation. The next stage is then observation and capturing that owner history. So starting with observation, we're going to do this through owner captured videos. So somehow you put these checklists in front of owners, or owners are coming to you with a complaint that may indicate osteoarthritis pain is present. The next stage of that diagnosis is observation. And now we go back to the owner captured video. So all of my comments earlier on pertain to this section. What I'm going to do now is just go through a few of these videos. I admit not all of these are captured in the home environment, but just a few of the videos to show you how much information you can glean from watching these videos. So let's take a look at this dog here. This is a slow motion video. So this is a video I took and then slowed it down. And this is to talk about forelimb lameness and identifying which limb is affected. So you can probably see as you watch that dog walk there that it is uneven at the front. And what we're going to do now is go through how to determine which forelimb is affected. Now, what we're looking for is the mnemonic down on sound. Actually, so the head goes down on a sound limb. So down on sound. And actually what happens is it's up on unsound. The head is being raised, pulled away from the forelimb when the painful or the more painful limb hits the ground. But up on unsound doesn't rhyme as well as down on sound. So the mnemonic is down on sound. Down on sound. What we're going to do is watch the dog. Every time the head bobs down, we're going to say down, 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 down. Then we're going to look at the limbs. When we say down, whichever forelimb is hitting the ground, that is the sound one. So the dog is lame or more lame on the opposite limb. Okay, hopefully this will all make sense. So here we go. Down, 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 down. Okay, so as I said down, I stopped the video there. You can see the right forelimb is on the ground. That means it's the sound or more sound one, which means the predominant lameness here is on the left forelimb. This dog actually has a bilateral forelimb lameness, but most severe on the left. So that's going through that. And now the next video, this is at normal speed. Let's take a look. And again, even within a few seconds, you should be able to see this. Down, 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 down. You see that? So, and that was down on that left forelimb, indicating that predominant lameness is on the right forelimb there. Now here's another one. Just watch this dog as it goes downstairs. I mentioned capturing video of going up and down stairs is really informative, and that video there tells me so much, as does this. So this dog, in terms of function, isn't having much trouble going upstairs, but just look at this. A great deal of hesitation and trouble going downstairs. You get the impression it really doesn't want to, and when it does go down, it puts both feet on the lower step at the same time. And the reason for that is that it has pain on both forelimbs, and it doesn't want to put all its weight excessive weight on one forelimb or the other. So it's trying to minimize the impact on an individual forelimb. Here's another video. We're going to move to the back end now, and you can imagine this would be a snippet of video taken in the home environment. And here we go. And that is all you need to see. Hopefully you've captured that there. Look at the back end of that dog. I'll play that video again, and look at the sway of that back end. Look at the sway of that back end from side to side. That is excessive movement of that back end. I'm going to talk about this a little bit more in the next video. So let's just watch this. Excessive movement of the back end of that dog from side to side, as well as actually a curved back that you can see there. This tells you a great deal of information. I mean, this essentially tells you that there's a very high likelihood of bilateral hip pain in this dog. And the reason I know that is that movement, the swinging the back end from side to side. So this dog wants to move forward, just as the dog in the previous video. But because of hip pain, they both want to limit flexion and extension of the hip, but they still want to move forward. So how do you move forward while limiting flexion and extension in particular of the hip? Well, what you do is you fix the hip joint and you throw your back end forward to one side and then round and forward to the other side. So that's how you effect forward motion while minimizing coxofemoral joint movement. And so that movement there, that movement is almost pathognomonic of hip pain. And also you see in this dog here that rounded back, which tells you there is hind limb pain. That dog has been throwing its weight forward, and as they do that, they end up with a rounded back. So much information you can gather from video captured by the owner. And here are a couple of bits of video. I've just sort of randomly chosen these bits of video here. So watch this one. We're watching dogs play in the yard, and look at this dog here. That gives you a lot of information there. So you see that bunny hopping, and when the dog stops, there's a particular first time it stops, it looks very uncomfortable on both forelimbs there as well, sort of stilted on both forelimbs. So that's telling you there's multi-limb involvement and very likely bilateral coxofemoral joint pain at the back end there. And then here's another one. This is my brother's little dog, a Spanish dog. Looks fairly happy, but look at that gait. Nice bunny hopping there. Occasionally individually using the hind limbs, but the bunny hopping there, and you can also see some of the muscle wasting at the back end. So just that short video, I can say there's a hind limb problem because of the gait abnormality, and that bunny hopping would be indicative of bilateral hip joint pain. So a lot of information we gather from these. Here is one more. This is a recent home consult. So instead of, as I've been spending time at home, I've had individuals visit my home, and I get the chance to evaluate their pets. And so what you can see here in a moment is, look at that hind limb swing from side to side. So a lot of hind limb swing there, slightly rounded back. And also get the impression that the stifles are not not functioning perfectly well. There seems to be some excessive movement there, very upright stifles. So again, just by reasonably good video captured in the home environment, it is a fabulous opportunity to evaluate these dogs. It's actually an opportunity that you do not get when they visit the practice. And I think, as we move out of, hopefully, this COVID-19 era, I will continue to use the methods, what I've set up to get video from the home environment captured by owners and sent to me as part of the evaluation. So useful. Don't ignore the bare patches in the lawn. Grass was never really supposed to grow in North Carolina. Okay, so now then in diagnosing, we also want to capture that owner history. This is certainly important to do as part of any evaluation of a new case. And we want to capture relevant history. So OA pain is usually a differential diagnosis due to mobility issues. So, but it's not the only thing that causes mobility issues. So one way of approaching this would be to create your own history form with set series of questions that covers history pertinent to not only osteoarthritis, but other diseases that may impact mobility, such as cardiovascular disease, neurological disease, as well as OA. So that might be one idea, to have a history form that relates to mobility issues. So as soon as that is flagged up as a problem, you pull out this specific form. You can also use CMIs to capture history in relation to clinical signs that pertains to osteoarthritis. And the one example here I'm thinking about is a Liverpool Osteoarthritis in Dogs Index. So there are two parts to the load. The part that I've already shared with you is the assessment part on the right of your screen, but then there's the owner history part. And I've shown you the front page there on the left, and here is the another part of that history form. So you can see here in the last week, on average, how far has your dog exercised, how many walks has your dog had each day, and other questions on what sort of terrain does your dog most often exercise. These are very relevant questions when you're looking to really understand what musculoskeletal disease is present. So encourage you to either think about creating your own history form, again, so that with set questions, so that the history you're capturing is consistent, or to consider using the history part of the load there to capture the owner history in relation to a mobility problem. Remembering, though, that load history doesn't necessarily ask questions that may pertain to other diseases that could impact mobility. And on that note, it's important to remember that not everything is osteoarthritis. I mean, I spent a lot of my life thinking about osteoarthritis-pain across different species, but not everything is osteoarthritis. Not everything that impacts mobility is osteoarthritis. And I think as you capture the history from the owner, as you look at those videos in particular, if you see, for example, a non-weight-bearing lameness, that is unlikely to be osteoarthritis. So a non-weight-bearing lameness could be, for example, an acute rupture of a cruciate ligament. It's more likely to be fracture-related, or septic arthritis-related, or nerve root tumor, or nerve root entrapment, luxation, than osteoarthritis. Osteoarthritis rarely produces a non-weight-bearing lameness. More likely in smaller dogs, very unlikely in large dogs. If you have a large breed, St. Bernard, a Great Dane with a non-weight-bearing lameness, that is not osteoarthritis, or at least that's the starting point. Crying out, yelping. If an owner says, "Oh, my dog's been occasionally yelping, crying out," again, unlikely to be osteoarthritis. To me, that speaks more of a neurogenic type of pain, nerve root entrapment, that type of thing. If the owner reports ataxia, stumbling, falling, sometimes owners confuse poor gait with ataxia, stumbling. So you may need to ask some further questions there, but that should be a red flag as to, well, maybe there is neurological disease present. But you'll see a lot of this when you watch the videos. Now, these two videos I'm going to show you are taken in the clinic, and these are dogs that were sent in for an evaluation of osteoarthritis. So let's just take a look at this. So certainly stilted, look to this dog, unhappy gait, but look at that wide hind limb stance, and look at that low carriage of the neck. And now this dog being very reluctant to turn around. Look at the way this dog turns. Head always held low, very wide hind limb stance. So for sure, there may be osteoarthritis here, but this looks neurological. And indeed, this gait here, this abnormal gait, is due to neurological dysfunction induced by intervertebral disc disease in the neck region. And in fact, its joints were absolutely clean, perfect. And then here's another one. I don't even need to play this video, do I? you know that this is a wobbler. Again, look at the very wide hind limb stance there, low head carriage, and this very, very difficult turn there, okay? All indicative of neurological disease. So just to reiterate here, the orthopedic examination for diagnosing and monitoring OA has a number of components. Our end goal is always to identify the location of OA pain and the impact of OA pain on that patient. And the hands-on orthopedic examination is an important part of that. But a lot of the rest of the OA evaluation can be done remotely. And I think what I've learned during this COVID-19 era is to improve what I'm doing in terms of observation by capturing video from the home environment, and improve what I'm doing in terms of capturing owner observation by using those clinical metrology instruments and using consistent history questionnaires. And then even prior to that, making use of those checklists that are available to screen dogs for the potential presence of osteoarthritis pain. So I'm going to finish up for a few minutes here talking about treatment efficacy for osteoarthritis pain, really in relation to managing treatment remotely. Let's start off by talking about where you'll see effective efficacy with respect to treatment, and that is around the non-steroidal anti-inflammatories, either the COX-inhibiting non-steroidals or the non-COX-inhibiting non-steroidals, such as grapiplant. Exercise, weight optimization, and dietary optimization. I'm going to touch on most of these areas in the next few slides. Firstly, I want to talk about non-steroidals. I think if I've certainly experienced colleagues who, because of the decreased patient contact, suddenly are more fearful of using non-steroidals. And particularly around, not being able to necessarily capture blood work as frequently as they might like. I guess, I certainly respect those feelings, but maybe it's just think, or let's pose some questions. How often has blood work actually altered what you were going to do in terms of using non-steroidals to manage OA pain? And that's an open question. I'm not saying blood work is not useful, not important in certain circumstances, but maybe for some people there's been an over-reliance on that. Also, the reality is that non-steroidals are very appropriately safe. So the incidence of side effects can occur with non-steroidals, but the incidence is very low. Indeed, this lovely review by Bea Monteiro-Stigal clearly shows that across all the published studies looking at non-steroidals, particularly those where there was a placebo arm, placebo-controlled blinded studies evaluating non-steroidals, the incidence of side effects was no different between the placebo group and the non-steroidal group. Absolutely, non-steroidals can be associated with side effects, but what I've just said about the incidence of side effects being no different between placebo and non-steroidal treated animals essentially means that side effects attributable to the non-steroidal occur at a very low level. So non-steroidals are well tolerated. And further, there is no evidence that long-term use of non-steroidals increases the incidence of side effects. That's probably because if side effects are going to occur, they occur in the first 2 to 4 weeks. And that's, we will instigate the use of non-steroidals for a defined period of time. 1, to see if they are efficacious, and 2, to make sure they're tolerated. Once we determine that they are efficacious and they are tolerated, they're likely to be tolerated well long term. I've talked a little bit about blood work already. Again, I think, I'm not dismissing it, but probably I would say more important is to emphasize that the most common side effects are externally visible. They are visible by the owner. And so actually, as part of our remote management, we need to be making sure that we emphasize to the owner that if there is vomiting, anorexia, loose stools, malaise, that they need to let us know. You need to contact us and take appropriate action from there. And I think very often we forget to have those conversations with owners, and that should be a positive conversation. There's great utility in the non-steroidals because they are going to improve these patients, but we do want to avoid serious problems, and so we make it clear to the owners to watch out for those observable side effects. Exercise is something that can be done in the home environment, and certainly I know in this COVID era, a lot of people have actually adopted dogs in order to have an excuse to go outside and get out of the house. And so I think for some canine patients, they're getting more exercise than they were beforehand. But exercise has great utility. The exercise induces an analgesic effect in and of itself. Exercise is as analgesic in terms of degree of efficacy as the non-steroidal anti-inflammatory drugs. And that's been shown in very robustly in humans. This meta-analysis here at the bottom of the slide clearly shows that there are comparable effects of exercise and non-steroidal anti-inflammatories. And we have some information from dogs as well, suggesting that about an hour of exercise a day is the kind of the minimal optimal amount of exercise that dogs should have. So exercise can be very effective. Let's move on to supplements, and my focus is here is on the omega-3 fatty acids. This is, that approach is supported by this review here by Van der Voort et al. And in this review, they look at the evidence for and against various supplements. This is a table from that publication. So they list all the high quality studies, they list the supplement that was looked at, and in the narrative, they indicate and conclude that the best evidence for an analgesic effect, we're just talking about an analgesic effect here, best evidence for an analgesic effect is with the omega-3 fatty acids. And so that to me is meaningful. Those were clinical studies, and so I do to a degree rely on the omega-3 fatty acids added to the diet to help with pain relief in these patients. And across these other supplements, for example, glucosamine, chondroitin sulfate, no clinical evidence of a meaningful analgesic effect. And I'll just mention on that note, these supplements are often used in the hope that they will modify disease progression. There's no evidence for that across all of these supplements. Now, this is an evolving area, and for example, there's been recent information come out on UC2, and so we need to constantly reevaluate the situation as studies are done, larger studies, better studies. Maybe the conclusions will change over time. And that also brings us on to adjunctive analgesics, in terms of talking about what are the things we would turn to and rely on. And one question is, do adjunctive drugs provide appropriate efficacy? I've seen a lot of people shy away from the non-steroidals and move to these so-called adjunctive drugs and rely on them. Well, here is a complete dossier, if you like, on the evidence of efficacy in dogs of 3 adjunctive analgesics: amantadine, gabapentin, and tramadol. With amantadine, a single study, positive results, but positive when amantadine was used in addition to a non-steroidal anti-inflammatory to provide extra pain relief. So that's an important point. Gabapentin, nothing. And actually, I looked this morning, still nothing. So we actually don't know whether gabapentin has any utility at all in the management of osteoarthritis-associated pain. Now, this is not to say I don't use gabapentin. The point here is I'm not relying on it. It is not a first line. I am not relying on gabapentin to produce pain relief in dogs with osteoarthritis. Tramadol, a couple of studies I've indicated here, mixed results in one very small study. But I think where we're settling out now, and I think Steve Budsberg's report really emphasizes this, that on a group basis, tramadol is no different to placebo. So we're not seeing a useful analgesic effect in tramadol. And I chose my words carefully there, on a group basis. There may be individual dogs who might benefit, but the overall message here is these are not appropriate first-line drugs or drugs to rely on for analgesic efficacy. How about other at-home options? Very easy to do, and certainly we believe it's effective, is to modify the environment. Create ramps so dogs are not struggling to get up and down stairs. Lower stool surfaces, make sure there's access to food and water. Massage therapy. I don't know whether any of you have had joint pain and altered the way you move and ended up with muscle spasm and pain in other parts of the body, but that secondary pain is often worse, as bad, if not worse, than the original joint pain. And the massage therapy can relieve that tension and decrease the pain burden on that individual. Cold therapy for flares, very old data, but certainly good scientific data to indicate that at least for the distal joints, so the elbow distally and the stifle distally, the canine joint can be effectively cooled. And so if there's a flare associated with an individual joint, you can empower owners to play a role in that treatment. I like these pliable freezer packs. Those are the freezer packs. These are the cold packs. You put them into the freezer, but when you take them out, they're still pliable. And apply those through a thin tea towel type material. Maximum of 15 to 20 minutes, maybe 2 to 3 times a day. And then there are other options that you may be using in your practice. Pulsed electromagnetic field therapy. You may have devices that you loan or sell to owners to use in a home environment. So think laterally, but remember to try and rely on those 4 initial pillars: the effective analgesic and non-steroidal, exercise, adding in omega-3 fatty acids, and optimizing body weight. In terms of follow-up, reassessment and reevaluation are important. And for all dogs, I would say a reevaluation 2 to 4 weeks after starting the non-steroidal. Ideally follow-up blood work, but certainly an evaluation and discussion with the owner about whether there's efficacy being seen and whether there are any outwardly detectable side effects. And then come back after 3 months. And so my basic approach to using an analgesic is daily administration for 3 months. Then I'll think about dose reduction, the so-called dose titration. And then maybe 2 to 3 months after that. Beyond that, I think for younger dogs, probably a minimum is every 6 months. For older dogs, a minimum every 3 months. And these are not hard and fast rules, but just guidelines. And I think, I'm giving you some figures there, really just reflecting the fact that other things can happen in older dogs. And I think you just need to be reevaluating them on a more frequent basis. So many thanks for your attention. And once again, I do hope you are all keeping well. And now I'll be very happy to answer any questions.
Thanks very much, Duncan. With the first question coming, that is considering that the owner is the one answering the questions, not the patient, has the influence of the owner perception on the true state of OA affecting his dog or cat being assessed?
So I think that's a very important consideration. Really, the psyche, if you like, of the owner and how that influences the answers that you get when these questionnaires are completed. There absolutely is an influence. Do we know how to control it? I don't think so. We've looked at things like dispositional optimism of owners to see whether that influences the answers we get. So I think there's an academic side we can go down, trying to understand the characteristics of owners and how that influences the answers. And so there is a relationship there. I think probably the biggest influence that we can have some control over is education. Once we educate owners about the signs, then I think we start to get more accurate data being communicated by owners through these clinical metrology instruments. That has not been systematically looked at, to my knowledge, in terms of what difference does owner education make. Probably most work in that area has been done in cats. Great question.
We have another question. Placebo effect, well recognized in human OA and seems to also be a reality in dogs or cats. Does it pass by the brain of the owner?
So this is fascinating. So when you run a clinical study, say you're comparing a treatment, and let's just assume it's efficacious against placebo, and it's blinded, you see responses in the placebo group. That is, the owners of animals that were receiving the placebo apparently see improvements. And that is the placebo by proxy effect, or sorry, no, that is the caregiver placebo effect. So owners want to see an improvement, and so they do see an improvement. And there's a lot of data on this in humans. If we expect something good to happen, we'll start to see it. We'll start to see those things happen. So that is the caregiver placebo effect. So the answers you get back are influenced by that. An even more interesting thing is the placebo by proxy effect, where because of the change in attitude of owners, you may actually see real benefits in patients. So when owners are more optimistic, pain will decrease in their pets. And in fact, there's other work that's indicated, and there's even some work that has suggested that if owners are more optimistic, cancer treatments work better and cancer spreads less easily through canine patients. So there's a very real connection here between owners and their pets, and there's a very real influence of how owners feel and act on actually really how their pets feel and act. There's a real effect on disease. It's not at a great level. It's probably around about the 5 to 10% level. So you've got two things there. One is you're always going to get this caregiver placebo effect. Owners will over-report positive findings, but then there is this placebo by proxy effect, so that if you can make owners feel happy and empowered, there may actually be some benefits for the individual patients. And that's something that it will be good to understand how to harness that.
Okay, we have another question. Do you use laser therapy for dogs with OA?
Yeah, so laser therapy, we use a class 3B lasers. Now, for me, those are in the tier 2, so they are not therapy. They're not first-line therapies that I'm relying on. They are added in once I have done an effective analgesic and non-steroidal. Once I have looked at increasing exercise, I've added omega-3 fatty acids into the diet, and I've managed weight. Once I've done those, if I need more efficacy, then that's when I start to look at what I'm calling the tier 2, adjunctive drugs, class 3B laser therapy, massage therapy, pulsed electromagnetic field therapy. So we do use lasers in that, add-on capacity. Now this is just, I've not looked at this in detail scientifically, but this is just my clinical experience. I don't think lasers do that much when they're applied over joints. I think they do quite a bit when they're applied over tense and painful muscles. So those dogs that have hip OA, tense, painful paralumbar muscles, that's where I think you see a great benefit to laser therapy.
Okay, we have another question. Can you tell me about the treatment of osteoarthritis on cats with chronic kidney disease? What dose of meloxicam can we use and how long?
Yes, so cats, all right, yes, quite. I could talk about that for a few days here, but I'm just going to touch on it.
Yeah.
Yes, yeah, just going to touch on it. So I think the first thing to say is non-steroidals can be used in cats with chronic kidney disease. I have a lot of experience with using non-steroidals in cats with chronic kidney disease, iris stage 1, 2, and 3, not 4. That's where I would avoid them. And my go-to choice is robenacoxib. If you look at the published literature, there is nice evidence that robenacoxib is appropriately safe. In fact, no different from placebo in cats with chronic kidney disease. I think that study was IRIS stage 1 and 2. And there'll be more data coming out looking at IRIS stage 3. And that's with the dose of robenacoxib that has been shown to be efficacious. That is my preference. Meloxicam, I think, can be used at lower doses. I would use lower doses, not the recommended daily dose. But then I think at some point you have to question, are those lower doses actually providing efficacy? The lowest dose that has been shown to be efficacious is 0.035 milligrams per kilogram every day. Once you go below that, that's when I think I would question, are you actually providing an efficacious dose? So there's a couple of things to think about there.
Okay. What about omega-3 fatty acids? Which one do you recommend and which are the doses?
Yes, a great question. And so my dose is 100 to 200 milligrams per kilogram per day. And that comes from looking at what is in those so-called joint support diets, where and they have been shown to provide efficacy, to decrease the clinical signs associated with osteoarthritis. So if that's what is in those diets, if that's what those dogs eating those diets are getting, that's where I've got that 100 to 200 milligrams per kilogram per day. That is a big dose. You know, you're all probably thinking, oh, 30 kilogram dog times 100 is 3, which I need to do that. 30 kilogram dog times 100, so that's 3,000 milligrams, isn't it? At 100, 6,000 milligrams at 200 milligrams per kilogram. And then you think some of these capsules, you know, may only have a couple of 100 milligrams of omega-3. So that's the dose. Moving on to the product, I look for fairly concentrated products to decrease the number of capsules or volume of liquid. And I use manufacturers that employ third-party analysis of their product. This is one of the things with supplements that has been realized in the last few years, is because it's all unregulated, you don't always know that you're getting what the manufacturer says you're getting. And so with third-party verification of that, that gives you a greater confidence that you're actually buying, and therefore the pet is getting what you think it's getting. So there are various third parties that are used to evaluate the omega-3 fatty acid content of products.
Okay. Another question is, have you seen better effects in the treatment with Galliprant instead of other nonsteroidals?
Yes, so I'm glad you worded it like that. So Galliprant is a non-steroidal. It just is a non-COX inhibiting non-steroidal. So Galliprant is acting further down on that arachidonic acid pathway than the COX inhibiting non-steroidals. My experience is it is no different. It's no better, it's no worse in terms of the efficacy seen. So it's certainly an option, and for me it falls into that non-steroidal category, just with the knowledge that it has a different mechanism of action to the other non-steroidals. But yeah, no difference in efficacy there. Okay,
and what about your experience with CBD in combination with non-steroidals?
We certainly cannot talk about canine osteoarthritis without talking about CBD these days. So here's what I think of CBD. Firstly, I think there is huge potential, really huge potential. I mean, if you think about the endocannabinoid system, there's a lot of potential to interact with that to produce pain control, maybe other benefits as well. So a lot of potential. Then you take CBD. Well, CBD at the moment, the regulations around it vary across the globe and even within countries. Here in the United States, CBD that comes from cannabis, the plant cannabis, is a Schedule I drug. So to have that on you would be a federal offense. CBD that comes from hemp is much lower down on the schedule list, so it's relatively unregulated, but it's the same product. It's CBD. So there's confusion over regulations, stigma attached to it. But I think most importantly, that market is completely unregulated. It falls into the supplement market, completely unregulated, and so you don't know that you're getting what anyone tells you you're getting. And then on top of all of this, we don't know how efficacious CBD is, and CBD is often a complex. The CBD products are often a complex mix of different chemicals, and so which exact formulation is associated with what type of efficacy, we just don't know. And we don't know what the potential side effects would be. So in summary, I would say a lot of potential, but at the moment, it's a quagmire of smoke and mirrors and misinformation, and we really do not know what to advise or what to use. I sincerely hope that some quality research gets done to guide us as clinicians as to how to harness the potential of these cannabinoid products, including CBD.
Okay, and we have another question about cannabidiol. Is there any evidence for using it for severe osteoarthritis?
Again, that falls into the same category as I've just talked about. No solid evidence to my knowledge, no. And that's not to say these things can't be used, but I think what we have to remember as clinicians who want to do the best for patients is, where is there evidence? Focus on that first. And then if we need greater therapeutic benefit, then we move to these add-on therapies, these adjunctive therapies, depending on owner considerations, on price, on what we have experience with. That's the way we should be looking at these.
Okay, and last question, do you use paracetamol?
Yes, so paracetamol or acetaminophen, I do use that. I don't think it has the same efficacy as the non-steroidals, either the COX-inhibiting non-steroidals or the non-COX-inhibiting non-steroidals. So I don't think it has the same efficacy. But I have used it, not usually as a first line in the management of canine OA, most often as an add-on once you're getting to that point where the pain is becoming very difficult to manage. Now, as an add-on, I think you have to be cognizant of the fact that you may be increasing the risk of gastrointestinal irritation, ulceration. I don't think it's inherently a problem with acetaminophen, but when you add it to other non-steroidals, I think you probably do increase the risk of gastrointestinal irritation. So when I use it, it's 10 to 15 milligrams per kilogram twice a day in dogs. And I've had a few dogs that have not tolerated COX-inhibiting non-steroidals, and I've tried acetaminophen as a base analgesic. Okay,
so those were the questions asked, and I have one question for you, Duncan, because this is always in the mind of the vet, that when they are prescribing a non-steroidal for a long-term period, they ask themselves if they can find a minimal dose, effective dose, if they are combining it in a multimodal approach treatment.
Yes.
What do you think?
I think the question really relates to dose reduction. I do think dose reduction is possible. I think you can do it effectively. But I think two important things. I think in order to get the maximum benefit, you probably should be providing the recommended daily dose for a prolonged period of time before you start dose reduction. So I think you can only do effective dose reduction if the whole dog has improved. So you have to provide the non-steroidal for long enough for that dog to improve to the point where there is less pain and you can start dose reduction. So that's the first thing. And really, I never start dose reduction until there's been a 3-month provision of the non-steroidal at the daily recommended dose. Then when you start dose reduction, and no one really knows how to do it, I think there is only one publication on it, and that's the one where we gradually reduced the daily dose a little bit. But actually, my preferred technique in the clinic is to increase the dosing intervals. So instead of daily dosing, I now do maybe 4 doses a week, 3 or 4 doses a week. When you do that, you have to monitor those individual patients carefully, because probably, you know, half of them you can effectively effect dose reduction, and the other half you can't. And so you need to be looking at those individual patients. It's not a guarantee that you can reduce the dose and maintain efficacy. It's a very much an individual patient thing. So 2 things: provide the non-steroidal for long enough to get solid improvement before you start dose reduction. When you start dose reduction, monitor those patients carefully to make sure that efficacy is maintained.
Well, another question came into my mind. As you work for translational medicine and research, do you think that in dogs there is also individual response as it's in humans for the different non-steroidals, that you may are prescribed one and then it's not working, and then the doctor is changing it?
Very much so, Anna, very much so. So absolutely for the non-steroidals, and I think that's something, I didn't talk about that, but when you start a non-steroidal, you should give that 1 to 2 weeks to see whether, one, it's tolerated, but importantly, whether it's actually efficacious. And if it's not, be willing to go to another non-steroidal, because they are, and we can get into this detail some other time, but they are different. Each drug is different, and they interact in their own unique way with the unique neurobiology that's driving pain in that patient. And so it's like jigsaw puzzle pieces. You know, you've got to find the 2 bits that fit together. So very much individual response to non-steroidals, and even beyond that, individual response to other therapies. And I think the future of both human chronic pain management and veterinary chronic pain management is to find some measure that we can do of the patient that will tell us which treatments, which individual drugs are going to be most efficacious. And that's where human medicine's edging, and we and others, and the Montreal group have been doing some work in that area. It's you know, that trying to find something that gives you that predictability, because at the moment, as a clinician, it's be careful with my choice of words here to make sure they're appropriate. It's we're guessing. I want to say crapshoot, but I shouldn't use those words. So we're guessing. And it would be nice to take an individual patient, measure something, and say, oh, I think this patient will respond well to drug X, therapy X.
Okay. And what time do you normally recommend if you switch from one steroidal to another one? 2 days or?
Oh yes, the washout. The
washout period. Which one?
Yes. I am going to say loud and clear that if you're switching because of a lack of efficacy, then a couple of days is fine, which is fairly rapid switching. If you're switching because of side effects, the washout period needs to be appropriate to allow those side effects to settle down. So as an example, if a dog's been vomiting, it has irritated gastrointestinal mucosa. And I think I remember from my histology that it takes about 5 to 7 days for cells in the little crypts to regenerate and climb to the top of the villi to reconstitute the villus surface. And so for me, just having remembered that, I think, okay, I'm going to leave 5 to 7 days before I go on to another non-steroidal. So switching because of lack of efficacy, pure lack of efficacy, rapid switching is good. Switching because of a side effect, the washout period should reflect enough time to allow that side effect to decrease. Oh, and just very, very quickly, if you're switching from aspirin to a selective COX-2 inhibitor, I would leave that 5 to 7 days, even if you're switching because of a lack of efficacy.
Okay. And regarding the reassessment for the X-rays, how often do you recommend to reassess the X-rays? Of course, there are other MRI, but for the X-rays, which are maybe the more frequently done?
Yeah, so I think, in terms of the initial diagnosis, it is nice to have those radiographs. The radiographs simply tell you that the signs you're seeing are referable to the disease of osteoarthritis. You can't, unless you're looking at muscle mass on radiographs, you really can't use the radiograph to say anything about severity of impact of osteoarthritis pain. So the initial radiographs are there to confirm the diagnosis. And so I think that helps with trying to tease through how frequently to do follow-up radiographs. Once you've made the diagnosis, you could argue you don't need any follow-up radiographs. So then the question would be, well, why would you take follow-up radiographs? Well, honestly, I would probably only do them if something changed. Because then what you're doing is you're reevaluating the situation and saying, okay, what has altered? Is there something else going on here? Is there a bone tumor? Is there a bone infection? Is there something going on in the spine? You're trying to understand why things have changed. So if the patient takes a dramatic change, that could be a very good reason for doing follow-up radiographs. And then, there's a degree of comfort for owners and for us as clinicians to repeat radiographs just to confirm what's going on. But I don't think there are any, it's certainly not in my mind, there are no hard and fast rules around when that should occur. Okay.
And the last question, would you recommend to do on a regular basis gait analysis in a platform, or is it more for research? What's your experience? Is it time consuming? It's not very reliable on a daily basis? Or
so it's there are pros and cons. It's certainly time consuming. The equipment has an expense associated with it and a space and time requirement. So, once you get the equipment, even with these mats that you roll out, and we've got one of them, once you roll them out, they take up space. So you've got to have the space to use the equipment, whether it's a fixed mat, force plates, or these roll-out pressure-sensitive walkways. If you have that interest in practice, then I think it's a useful tool. But you also have to remember what it's telling you. It's telling you about limb use, and limb use certainly relates to joint pain. But then if you think about it a little bit more, they're most useful when you have a single limb that's affected. So just as an argument, here's a little dog. If this dog is equally lame on all four limbs, it's still going to put its body weight onto the floor as it walks along, and you will get normal ground reaction forces. If it is lame on one limb, then you'll see the abnormal ground reaction forces on that limb. You provide a treatment, you see those improve. So gait analysis, capturing kinetic variables or even body weight distribution, is most useful if there's a single limb affected. As you move towards multiple limbs affected, I think its utility, whether it's in the clinical research, becomes much less. I think the future will be in some sort of analysis of movement through analysis of video. You can imagine the future where you hold your phone up, there's an app, and the app tells you how bad the problem is.
Mm-hmm. Okay, so thank you very much. Thank you for your time, and we hope we will collaborate in the future. Well, next November we will have another meeting, International Congress, so we will have you with us again very soon.
That's right. Okay. Looking forward to that. And again, apologies to everyone for the hiccup at the start there, but I certainly hope you've enjoyed the webinar, and feel free to reach out if you have any specific questions. And remember, this, Elena, this will be on the Academy website, won't it?
Well, we are going to send the link of the recording after the webinar, and we are trying to fix a YouTube channel. So we may have also a YouTube channel, but we have to fix it. But for sure, they will have the recording. Yes.
Lovely. Okay, and we can insert those videos and make sure that they run smoothly for everyone.
Now, Alexander has shared the link for the other webinar that was done for telemedicine in the USA during confinement. So we hope with all this information, you can have a better achievement of virtual care, which is something that vets we normally do. We answer the questions on the phone and we answer the owners after the visits. So thank you, Duncan, and see you soon.
Thank you very much.
Bye-bye.
Thank you, everyone. Bye.